The broadcast is now starting. All attendees are in listen-only mode.
Hello, welcome to HSG's educational presentation on the 2021 Medicare Physician Fee Schedule Final Rule. I know that most of us have been waiting for this for a long time, and we felt that we would do an extensive review of the final rule and present the pertinent elements, at least from our perspective, to you all. This session may be a little bit longer than what we're used to, and it may cover some things in greater detail than we have in the past, but there are some significant changes that CMS is putting out in this final rule, so we felt it appropriate to be somewhat detailed. I'm Terry McWilliams. I'm Director and the Chief Clinical Consultant with HSG. Not on the session with me this morning, but contributing greatly to this presentation were Neil Barker, a partner in the firm, and Eric Andrioli, a fellow director. I really appreciate their expert assistance in helping to develop this presentation and to be sure that we're presenting data as accurately as possible to you throughout this session. So what we would propose to cover in this educational session is a little bit about the physician fee schedule background and what's behind it and what it does. A summary of the changes, and we'll focus first on some of the changes that are significant but perhaps not as well known in this final rule, and then provide greater detail of what I would refer to as the big three items coming out of this final rule: the E&M coding documentation changes for the common office-based E&M encounter codes. Those are 99201 to 205 and 99211 to 215. And how the coding criteria have gone from the 95 and 97 guidelines for these codes to total time spent on the day of service or medical decision-making complexity. We'll also touch on the changes in RVU values for these codes, the 99201 to 205 and the 99211 to 215, but also the trickle-down effect on many other codes. And that's something that hasn't got as much press, but is truly a significant impact across the board. And then finally, the impact on the conversion factor for this year, which is decreased to create a budget neutrality factor with the notable increases in RVU values. We'll then look at a bit at what the impact on reimbursement might be and what you can anticipate. And then there's been a lot of talk about provider compensation impact, and that, of course, as is inherent in the variety of models out there, that will quote, it will depend, right? It'll depend on the model that's in place. So that's what we would propose to cover this morning, and we'll see how well we do with it from your perspective. So just getting into the Medicare physician fee schedule background information. So the fee schedule annually determines the reimbursement requirements and rates for most services provided by physicians and other qualified health professionals at all sites of service. The fee schedule also is a mechanism for CMS to promulgate other regulatory issues, and what they've done most recently with the fee schedule rules is combine all the updates for the quality payment program, whether the MIPS pathway or the advanced APM pathway. They also provide updates about the CMS ACO activities, and notably this time the MSSP programs. So it's also a vehicle besides the actual reimbursement elements, also a vehicle for regulatory updates. The proposed rule for this year was released on August 3rd and published in the Federal Register on August 17th. The 60-day public comment period closed on October 4th. Usually the final rule is released around on or about November 1st, but CMS presaged the COVID workload factors and indicated that the final rule would be released on or about December 1st, and in fact was released late in the day on December 1st. So most public viewing occurred early on the 2nd. The final rule is available at the link that's provided. This is the pre-publication final rule. It's a double-spaced document that spans more than 2,100 pages. That document is due to be published officially published in the Federal Register on December 28th, and at that time it'll be in the 3-column small pitch Federal Register format. The version that's available through the link, I think, is a little bit easier to read and follow. So I think it will still be valid. Well, it will still be valid even after the publication in the Federal Register. It'll just have a different appearance. So the major themes for the CMS data for the 2021 final rule was essentially the same as the 2020 final rule. They continue to work on trying to reduce the administrative burden of healthcare, consistent with their patients over paperwork initiative. They have again a long-standing desire to improve the accuracy of outpatient E&M coding and payment processes, and they will have said that any initiative they undertake, they'll consider the impact of evolving healthcare delivery, meaning they're driving healthcare evolution to create systems that have better accessibility for patients, higher quality of care, greater affordability, empower the patients and the providers, and all the while looking to innovate and not just rely on status quo to achieve these ends. With that, here's some of the summary of changes. I mentioned the big three in my mind, as we mentioned, the Office E&M coding documentation changes for the 99202, actually, we'll say 99201 to 205, and 99211 to 215. With the change in documentation going to total time the provider spent on the day of service, or revised medical decision-making complexity in determining the code assigned, that essentially eliminated code 99201, because the differentiator in the past on the 1995 and 1997 criteria between 99201 and 99202 did not relate to medical decision-making. It related to the number of systems reviewed or the number of systems examined type of thing. Those elements are no longer going to be part and parcel of the code assignment, and we'll talk about that in greater detail later. So with that, the complexity of care between the 99201 and the 99202 became essentially the same, and allowed for elimination of the code 99202. These changes were part of the 2020 final rule that CMS promulgated last year. This year, it codified that change and indicated it will be in place by January 1st of 2021. The second element of the big three is the increased RVU values for those same E&M codes. Actually, the value for 99202 and the value for 99211 did not change. So it's really the codes 99203 to 205 and 99212 to 215 that had the changes. With those changes in RVU values for those codes, however, the changes have a trickle-down effect for many other E&M codes that are based, at least in part, on the coding parameters for the ones listed. Notable ones in these areas, end-stage renal disease bundle, are all predicated on combinations of those codes. So the dozen or so codes associated with that changed. maternity services and maternity care bundled services changed for the same reason. The Welcome to Medicare, the IPPE encounter, and the annual wellness visit encounters both changed and increased, as well as the transitional care management code. All the emergency medicine codes at all 5 levels changed, and then psych services changed as well. So these are just part of it. The other part applies to the so-called missed value codes that are considered every year. And those had a significant number of changes based on these E&M coding changes from this final rule. So we'll look at some of those and the impact of those in greater detail. And finally, as was mentioned already, the conversion factor decreased to about 10.2%, down to $32.41. And as I mentioned, that's required to maintain the statutory requirement of budget neutrality of any RVU increase. So for instance, what that means is there's a legislative requirement, meaning a congressionally passed law, that any change in RVU has to be offset by a decrease in the conversion factor. So the total cost associated with on the CMS budgetary side has to be neutral. So it's a zero-sum game. And with the increase in values of the E&M codes that again were finalized in 2020 and codified again this year, that they would go into place on January 1st of 2021, there had to be a concomitant decrease in the conversion factor. Now, during the public comment period, many groups requested that CMS reconsider this and look at other options rather than having a full 10% decrease. It's a little bit less than the proposed rule, which was 10.6% decrease. But CMS went ahead with all of the changes as finalized in 2020 and codified in 2021. Since the publication of the final rule, a number of groups are making appeals to Congress for relief, similar to Congress relief that happened under the previous compensation change formula, the SGR. So we'll see what happens with that. Considering we're more than halfway through the month of December, I don't think that anything's going to happen before January 1st. So I think this is what we're going to be looking at, come the new year. If we look at some of the other additional, what I would interpret as significant changes that are contained in the 2021 final rule, there were a number of things with telehealth services. So as the first category are permanent additions to the authorized list of telehealth services. These are so-called category 1 elements, and these are items that CMS will always pay for regardless of the current COVID public health emergency. So home visits are going to that list, cognitive assessment and care planning services, group psychotherapy and psych and neuropsych testing, and then the 2 new prolonged service and visit complexity codes are going to be available for telehealth as well. There is some SNF related codes that are included as well. So CMS created a new category, this category 3 telehealth services. These are telehealth services that are limited to the COVID-19 public health emergency. What CMS did was make sure that they extended the coverage through the end of the calendar year that the public health emergency ends. So right now, unless something changes drastically, the current COVID-19 public health emergency from the federal government side expires, I think it's on or about January 21st. So that all of the things that are listed category 3, the reimbursement from CMS will continue through the end of calendar year 2021. If the COVID-19 public health emergency is extended into 2022, unless the 2022 final rule changes this would take them all the way through the end of the calendar year 2022. So for right now, it looks like that all these category 3 codes will be reimbursed similarly from the Medicare side through the end of calendar year 2021. These include all levels of ED visits, physical and occupational therapy codes, critical care codes, including pediatric ICU and neonatal ICU, hospital day of discharge codes, and observation, subsequent care, and discharge codes. So all those would carry through the end of the year and be covered in a telehealth fashion by CMS. Now, note, I keep trying to emphasize this is based on Medicare, not commercial payer. So this is all Medicare. The SNF visit frequency was in current regulation is allowed to be offered virtually once every 30 days. The proposed final rule proposed to have it covered once every 3 days. Public comment of the prolonged nature of these care situations led CMS to increase the frequency permitted to once every 14 days from every 30, but did not go up any more frequently than that. Most of the public comments felt that that was a very reasonable time frame, and if a resident of a nursing facility needed intervention more frequently, it probably needed to be in person. The telephone-only requirement, you'll recall that CMS is now covering audio-only visits during the COVID-19 public health emergency. The 2021 final rule confirmed that they will discontinue payment for audio-only visits after the public health emergency abates. They did solicit comment about a long-term audio-only component, but they did not do that at the present time. The virtual direct supervision aspect is being continued through the end of the PHE or the end of 2021. There was a patient safety concern mentioned about a global permanent adoption of virtual supervision because regulatorily now, in a non-COVID environment, the supervising clinician is expected to be immediately available, meaning essentially on site. There's not a requirement to be in the same room, but there is the requirement to be available to offer assistance if assistance is acutely needed. There was some desire across the country to have that be a permanent adoption and allow that to be permanent, and CMS declined. However, and this is an interesting however because I'm trying to reconcile it still, if you felt there was a need for direct supervision to be immediately available across the board, and that's why you wouldn't make it permanent, CMS is made a permanent adoption of virtual precepting or supervision outside of a metropolitan statistical area. And the feeling was the benefit of increasing rural access to care and promoting rural residency opportunities exceeded the potential risk of the preceptor not being immediately available. I'm not sure how that applies in one situation versus the other, but according to the final rule of 2021, there is the permanent ability to offer virtual precepting and supervision outside of an MSA, which puts it into a rural setting with the purpose of trying to promote greater access to care in the rural environment and greater number of residency opportunities in a rural environment to continue to promote access, rural health services. And this has been a focal point for CMS over the last number of years, is trying to increase care, access to care, and the type of care available in the rural environment. So they felt that this was more consistent with that and had less risk and greater benefit. So they went with that change. So the communication technology-based services, and just to refresh memory, we talked about telehealth before, and this is similar to telehealth, but not falling under telehealth regulations. And so CMS has a separate category, CTBS, which they've finalized areas of care over each of the last several final rules. This is the non-face-to-face care that is not subject to telehealth regulations, but is codified and reimbursed by CMS. These include things like the virtual check-in we've talked about in the past, which is code G2012, the virtual images interaction where you review images and then decide plans of care, which is code G2021, or excuse me, 2010. And it's that type of interaction that we're talking about here. In the 2021 final rule, CMS confirmed that consent can be obtained and documented by auxiliary staff under general supervision. It does not require that the provider obtain the consent, and that was just a clarification. The provider does have to do the non-face-to-face care for these codes, but does not have to get the verbal consent. CMS also is permitting licensed independent clinical social workers, clinical psychologists, physical therapists, occupational therapists, and speech pathologists to bill for online assessment of established patients. The distinction here is the others were targeted at credentialed, qualified health professionals like physicians, APRNs, and PAs. This expands that possibility to other direct care providers with different CPT codes, and added a new virtual check-in and virtual images code for these individuals. So you'll notice that the requirements are the same. So the requirements for the G2251 is the same as the requirements for the G2012, and the requirements for G2250 are the same as the requirements for G2010. But the differences in codes just reflect the differences in the rendering provider. CMS also added a new code, the code G2252, which is basically a prolonged services code for a virtual check-in encounter. So all of the elements for the virtual check-in code, G2012, apply, but the duration of the encounter is 11 to 20 minutes as opposed to 5 to 10 minutes. Since it applies the same criteria for the virtual check-in applies, it does need to be a synchronous communication by a qualified health professional, physician, APRN, or PA as a rule, but it can include audio communication only. The RVU value is noted. It was linked to the mid-range audio-only code. Remote physiological monitoring, a lot of clarification of existing policies. CMS did indicate, as was expected, that once the COVID-19 public health emergency abates, this will only apply to established patients and will not apply to new patients. It clarified that auxiliary personnel within the practice can provide the initial setup and data transmission codes under the supervision or incident to a billing practitioner services, and clarified that the existing policies will be in place over the long term. So again, just the clarifications there, and we'll leave that for your future read. Significant in scopes of practice, several. One is indicating that these groups of qualified health professionals, so NPs, CNSs, CNMs, CRNAs, and PAs, can supervise the performance of diagnostic tests. This is fairly big because under CMS regulation, they could order diagnostic tests, but only physicians could supervise the tests. So now they're permitting performance of diagnostic tests for those groups. They also clarified that pharmacists could be included in auxiliary personnel under Incident 2 regs and requirements. This is significant with the inclusion of pharmacists in many of the new care delivery models. CMS indicated and reiterated that pharmacists are not statutorily designated qualified health professionals. So according to congressional legislation, They aren't included in that grouping, so they cannot bill Medicare directly for services rendered. It's a law, it's the easiest way to say it. But what they did do was to include pharmacists under auxiliary personnel, because if you think about it, they would never have been part of the office-based support staff. And now they're making sure that anything that applies to any auxiliary personnel within the office setting now applies to pharmacists as well. They also granted a permanent position for physical therapists and occupational therapists to delegate maintenance care to PTAs and OTAs, or physical therapy assistants and occupational therapy assistants. In the past, CMS required physical therapists and occupational therapists to be the provider for Medicare patients for all incidents of care in therapy. This was felt to be, I think the best way is not cost effective and not clinically relevant. And so they've come around and they're permitting this delegation long term with a reimbursement at 85%, very much like the physician versus APP levels of reimbursement. So this should actually be a big thing in rehab and allow for greater equal footing about cost-effective care in organizations. An element that will affect your welcome to Medicare and your annual wellness visits is that the Support Act, which stands for a longer thing that I can't remember right now, required that these visits first screen for potential substance abuse disorders, and second, review any current opioid prescriptions. CMS felt that the current process would probably cover that, because there is a screen. Most people think, though, when they were thinking of substance use disorders, it was alcohol as opposed to opioids in this age group. And since there's a medication reconciliation and reviewing all current medications, that would include any current opioid prescriptions. But again, there's going to be an emphasis on looking for illicit substance use, as well as utilizing prescription medication for non-prescribed purposes. And so I would envision there might be a little bit of shift coming out in the guidance about the inclusion of these elements in those exams. And so our processes might need to be tweaked a little bit in the office setting. CMS also introduced a new code for 30 minutes of psychiatric care management as part of their care management suite of services. Previously, the code was only in place for 60 minutes or more. So this recognizes that there's a lot of care that's rendered that may not have previously been able to be reimbursed, but was very important. And so this tries to fill that area. And this is the whole part of their psychiatric collaborative care model, to make sure that, again, there's parity between medical and mental health services, but also to make sure that we're expanding our care management applications across the board to enhance care for beneficiaries. And the other elements of that code are there. They maintained vaccine administration reimbursements at 2019 levels. They had been annually adjusting and I believe actually decreasing. It was felt that with the emphasis on vaccines, with the coming COVID-19 vaccine, with the emphasis on flu vaccines right now, and the adverse financial impact of many of things over the past year, that they would maintain vaccine administration reimbursements at the 2019 levels. The electronic prescribing of controlled substances was a requirement that was going to be implemented. The requirement was to be implemented this calendar year, 2021, and compliance in 2021, if I remember correctly. The adjustment is implementing, having the requirement implemented in 2021, but not looking at monitoring compliance until 2022 to give organizations more time to ramp this up and comply. Now, for some states, this is for practices in some states, this is not going to be a new requirement. So, for instance, 10 states currently require electronic prescribing of controlled substances. and 16 other states have effective dates that'll occur in 2021, many of them on January 1st, which would be coincident with the original timelines. But you notice that's only 26 out of the 50 states plus District of Columbia plus colonies. So it's basically only half. Those states that don't have anything on the books, and if you're practicing in those states, this is going to really be an issue. And so, looking at making sure the EMR has the ability to do that, looking at updating your platform to be able to do that, having the processes in place because there is some registration involved and a few other things. I just put this out there because it's coming, and especially for the states that don't have anything on the books starting in 2021, nor have state legislatures been really proactive about this. This could be a huge deal. If you look at where we are across the country with this, there's a large swath of the country encompassing many practices that don't have a law in the books. So look for this, be mindful of this. Secondarily, there were things in revising the FQHC market basket and the laboratory fee schedule, and also delaying a bit the appropriate use criteria implementation. This is essentially will be a Medicare pre-authorization service. That's my interpretation. It's not theirs. There's a lot of legislative background to this. In fact, this program was started with legislation way back in 2014. They had announced in August that they would extend the educational program period and individual testing through 2021 and not have payment consequences to at least 2022 as opposed to starting in 2021. It applies to advanced imaging clearly. Here's a bit about the design for those who aren't particularly familiar with it. I won't go over it in detail, but it is here. And it basically requires a digital review, for lack of better. It was to be fully implemented on January 2022, but some of the changes will delay that. I mentioned that the 2021 final rule also applied to the Medicare Shared Savings Program. There are a number of things that changed with this. One is the elimination of the web interface and being replaced with a new APM performance pathway, or the APP as they abbreviate it. And this accomplishes reporting for both the ACO piece, the MSSP piece, but also the MIPS reporting process. It decreases the number of quality measures that the ACO must report from 23. You'll recall that there was a 34, that now down to 23, and now this will be down to 6 defined specific measures through the APP process. And it increased the performance expectation so that with this, the ACO will be expected to perform at a threshold of 30th percentile for 2021 and 22, and then to the 40th in 2023. CMS estimates that 95% of the ACOs would achieve that score based on 2018 data, so it shouldn't be a significant hardship in spite of all the public comments. CMS had proposed to go straight to the 40th percentile, but back down to the 30th percentile for the next 2 years because of the public comments. But I'm thinking if 95% of the ACOs would have achieved that scores based on 2018 performance data, I'm not sure I get it. But anyway, that's where we are, and that's some of the more significant MSSP changes. So, E&M coding documentation. The first of the big three that we'll talk about, CMS's goal in this was to continually reduce the administrative burden, improve payment accuracy, and update these codes to better reflect current practice of medicine. It's been, 15-ish years since the implementation in 1995, and then the more specific 1997 coding guidelines. And it was felt that care today was well, let me rephrase that. Many individuals had commented that the coding requirements based on checking the box mentalities of examining or reviewing this many components of the history and physical examination just really wasn't pertinent to clinical care. You know, the elements of the history and physical that are pertinent to the presenting issues were felt to be those that were, quote, medically necessary, and that most of the coding parameters for the 1995 and 1997 framework were onerous and not pertinent to clinical care. So CMS, taking this under advisement, has been looking over the past several years at changing this documentation. They're working in conjunction with the CPT editorial panel for these codes, and they've changed what they were going to do. You might recall that the final rule several years ago indicated that they were going to combine the level 2 to level 4 visits, just have a level 1, a mid-range, and an upper. They pulled back on that last year. And so what they're doing now for January 1st, 2021, is they're maintaining all 5 levels for established patients. As we mentioned before, they're eliminating the 99201. They're permitting E&M level determination by either medical decision-making or total time dedicated to the patient encounter by the provider on the date of service. They're revising some of the times and medical decision-making criteria involved in this, and we'll talk about that specifically in a minute. And they're looking at a medically appropriate physical history and physical exam for the encounter. I need to emphasize, and it's bolded on this screen, these documentation requirements are only for these codes. The documentation requirements for all other codes remain the same. They are not changed by this. The only things that change are the ones associated with 99201 to 205 and 99211 to 215. Any other code does not change. It's only these ones. And these change for every specialty that uses these codes. Many people think, well, we need specialty-specific coding education anytime that the coding parameters change. And frankly, this is one of those times where that's not the case. Anybody that uses these codes follow the same parameters regardless of specialty. All right, so let's start with the total time change. And as I mentioned and emphasized several times already, this is the total time the provider dedicated to a patient on the day of service. So the calculation only applies to the date of service only. If you provided if the face-to-face encounter was today, yesterday's time doesn't count, tomorrow's time doesn't count, it's just today. It includes the face-to-face encounter time and any indirect care time dedicated to that patient interaction that day. So if you reviewed tests, if you reviewed other consultant notes or other records than your own, any orders for medication, tests, procedures, consults, your chart completion done that day, any communications outside of the face-to-face visit with patients, families, and others, including consultants and others who are involved in the care of the patient, all those things can come together for total time of service, but only the time the provider dedicated to it and only on the day of service. So you can't count support staff time who did phone calls for you or work for you. You cannot count things that related to today's encounter but were done before today or after today. It's only today. You'll recall that the current coding criteria only allows time to be a factor if more than 50% of the face-to-face patient encounter was spent on counseling or education or care coordination or any combination of that. And it only applied to the face-to-face encounter time. It did not include any of the work outside of that time. So for those of us who complain about pajama time to get all of our charts done the day of service, this is recognizing that, and this may help you in accounting for that time, depending on several factors that we'll talk about it in a minute. Now, CMS adjusted the time expectation per E&M code accordingly. Since more time outside of the face-to-face encounter can be included, then clearly they couldn't use just the face-to-face encounter time to determine, the coding level. And they adjusted the actual time based on the AMA RUC recommendations rather than a different total time. But with the adjustments, this may alter the coding level if we just went with time. So, for instance, we'll look on this chart. The current total time is in that second column from the left, and that again was just limited to the face-to-face encounter. If we look at the total time for calendar year 2021, and this is based on table 20 of the final rule, we note that except for the lowest codes, the 99202 and the 211, all of the other codes had a fairly significant increase in the time expectation when we added the time outside of the face-to-face encounter. I had been anticipating seeing many things based on that third column from the left time frames, but note that on the far right column, the AMA CPT 2021 Professional Edition, which is cited by several sources, indicate time ranges, minimum to maximum, before going to the next, which are actually more in line with the face-to-face times in that second column from the right, rather than the published, we're going to accept these as total times. So I was skeptical that perhaps the AMA CPT 2021 CPT codebook may have had an error. However, if we go to the final rule, table 26 on the final rule and table 27 on the final rule, when we're talking about prolonged services code, and we'll talk more about that in a second, they listed this time here, of 60 to 74 minutes. Let's see if I can get this to work for us. This time on this slide, and this time on this slide, corresponds exactly to the CPT codebook times. So, as we look at this, I'm going to say, since the final rule had these ones correct, then I'm thinking that this is likely what's going to be there for utilizing final time for 2021. I could be wrong, and if so, we'll go ahead and put out a disclaimer. I could not find anything that would emphasize that, including the guidance that the MGMA put out for practices yesterday. They stayed away from this entirely and did not get into any detail related to this. So we'll go with this as likely the area that we're talking about for coming up and final time ranges. We did mention the issue with having a new code to look at time spent with a patient on the day of service, or dedicated to the patient on the day of service, that exceeds the upper time frames listed for the five level codes. So this new prolonged services code is G2212, and it applies when the maximum times for the 99205 and 99215 are exceeded by 15-minute increments. This code would be listed in addition to the base 5 code, meaning 99205 or 215, and only applies for intervals exceeding the 15-minute increments, right? So again, if we go back to looking at having an upper time of 74 minutes, 15 minutes after that gets us to 89. And so you have to get to the 89th minute before this code applies. And then that same code applies for that 15-minute interval. If you start to exceed that, then we can go to the next and the next. So what ends up happening is you have the 99205 followed by a series of 2212s for every 15 minutes that start beyond 89 minutes, basically. A similar situation then applies to the 99215 code. We already talked about, that being the base. So 15 minutes beyond the maximum gets us to 69 minutes, and then every 15 minutes thereafter coming down. So you'd end up with a 215 followed with a series of 2212s to end up generating the total time. Pretty straightforward and all. Now, determining total time is going to rely on being able to capture that. And so how do you capture it? How do you document it? Well, the first thing that's very simple is that the total time has to be entered into the note. So if you're going to use total time to code, then you have to put that total time in the note somewhere. So for instance, a line, something like dedicated 45 minutes in this example to the patient encounter on the day of service, list the date, and that then allows the opportunity to bill for total time and document it in the record. But it brings up how do we know? Do we have to do time logs similar to an attorney who accounts for every minute with a client? Well, most physicians that I know detest time logs, so that's going to be difficult. And plus, for me, keeping track of my time and what I dedicate to different areas over the course of the day becomes very difficult. And so I look for things that how can I know how much time I actually spent rather than trying to figure it out by my guesstimation of memory. So one element in doing that is sometimes our EMR can help us. So for instance, as we're doing things in the EMR, they can help us with things like how long we were in the chart, doing chart review, or how long we spent in the face-to-face encounter, if there's a tracking system in place. How long it took me to do the note. Some of those things might be able to be tracked in the EHR. Sometimes we lose track of how long we spent on the phone, and many of our phones can now tell us how long we spent on a given call. So we can find that information as well, and having it tracked in the phone. I think, in looking in my mind, how would I do this? I'd probably go with some kind of flowchart or time log, as onerous as that is. But again, this is only if we're going to be using total time. The other question that comes up is how will they audit this? So that in 2022 they're going to start auditing these functions just as they do now. They look for outliers and they come back and do chart audits. Well, one thing is having it in the note. There's another thing, since all these different elements that come into it are not required to be in the note. The only thing that's required to be in the note is the total time. And in this case, it would be I spent 45 minutes, and that therefore led to my 99213 code, or excuse me, 215 code, based on the time thing that we just looked at. But how do we prove that? And I'm not sure. And this is where some of this kind of comes in, because administrative rights in EMR access, anything that's tracked in the EHR, they'll be able to come and get, right? So I'm not sure how the audit function is going to work, but clearly some of the things will need to be auditable. All righty. The other thing that comes to mind in looking at total time is this may precipitate a reevaluation of our workflow. So for instance, if I spend time the evening before reviewing charts for the next day, so I'm prepared for a huddle in the morning with my staff, this may not be cost effective if I'm going to work on total time. If I complete the record after the day of service, I can't count that in that day's total time. However, if I spend time at night on my own, on the day of service completing records, that does count. And so that can make me feel a little bit better spending the time in the evening. But it would have to take me over the threshold of wondering how much total time to is it worth documenting total time versus the medical decision-making process. Similarly, I may put off calls with consultants or family members until after the day of service because it's more convenient to do tomorrow than today. But again, anything I do that's not today doesn't count. So if I then try to jam all this into today, estimates about how long it would take to do everything that's expected of every patient in a standard day in the office has estimates that approximate 20 hours a day. Clearly, we can't put everything related to today's services into today if those estimates are correct. Similarly, trying to do that is rather antithetical to the axiom of the more work that can be done before the day of service allows the day of service to flow more efficiently and with less surprises. So, many of us have been taught throughout that preload so that today, the day of service, goes well. But any time that you did pre-today won't count in the total time. Notice that we keep saying that this does not apply to your support staff. So support staff reviewing records the day before to be able to hubble the day of are not impacted by this, but what you do does. And so it's going to be tough for anyone outside of you to figure out how this best fits into your flow. But we'll just mention all these various parameters and things to think about because this is pretty huge. And all these start to become effective on January 1st. So it's only a couple of weeks away. So really, if we're going to shift and look at total time, there are a number of things that we need to do differently on day one of 2021 if we're really going to be able to do this out of the gate. Now, clearly, this doesn't mean you need to do it out of the gate, right? So as we go along, you might get a feel for all these. And as you use either total time or medical decision-making for your coding assignments, it'll hopefully become more clear which is more advantageous. And again, since this tends to be an individual thing, it may be individually different in how you deal with it. So those are the total time parameters in coding assignments for these codes. And again, it only applies to these codes: 99202 to 205 and 99211 to 215. The other option for coding assignment is medical decision making. Now, medical decision-making has been part of the coding parameters, both the 1995 and 1997 coding parameters. But we've focused more on checking the box for the history and physical elements and components that were the most identifiable, the most auditable, the most, quote, objective of the medical decision-making criteria. And our EMR documentation templates focus heavily on those, right? Click the following boxes to make sure you get credit for systems reviewed and systems examined. Our current EMRs, at least all the ones that I've worked in, and that's been a number, the EMR documentation is historically heavy on the H&P elements and historically very light on things like differential diagnosis and the decision-making thought process. You come down, you checked all your boxes and did all your things up on the top part, and then you come to assessment, you put in an assessment code, you put in your orders, and then you move on. Any amplification of differential diagnosis or decision-making thought process usually required free text comments, which didn't translate over into data points, right? And often we relied on the secondary inferences, right? So, well, if I had that diagnosis and I changed a medication, then clearly something wasn't right. There was very little connection. Now with the new 2021 medical decision-making elements, these connections are going to need to be more apparent in my mind and can't be implied. So again, this can create a little bit of concern and some consternation that we might have to change our documentation patterns to be able to more fully cover this. So with that, let's get into some of the elements. there are three areas or three major element buckets, if you would, that make up the 2021 medical decision making process or credit. The first is the number and complexity of problems addressed during the encounter, and it's only those that are evaluated or pertinent to the encounter. So importing the problem list won't help you because it has to be specific to this encounter. And just importing the problem list won't address this. It's whatever you address during this encounter. The second area is the amount and or complexity of the data that you reviewed and analyzed. And this applies to each unique test, order, or document reviewed around that visit. Note that unique test in CMS interpretation is that if you order a test bundle like a CMP, it's a single test. And so for instance, Chem 7, Chem 12, whatever, is not 7 tests or 12 tests, it's one test. So just keep that in mind. Similar nuance in this category is the independent interpretation of results listed as a category is actually reviewing and providing an individual interpretation. So it's not just reviewing a report. Reviewing a report fits up into the other, test order function. And you cannot include this as a piece of this exam complexity if you separately bill for interpretation of that service. So for instance, if you're a cardiologist and the EKG done in the facility is the one you're talking about interpreting, but you bill separately for interpretation of that EKG, you can't include that in this. That would be double dipping, right? So the interpretation might be, did a chest x-ray before it was officially interpreted. I looked at the x-ray and my review of the x-ray says this. And you're not billing for the interpretation. It's just directly related to your part of providing care that day. The third element in the medical decision-making process is the risk of complications or morbidity or mortality of the patient management decisions process. And so as you look across each of these, and we'll get to what's in each of these in just a second, you look at the highest level achieved with at least 2 of the 3 elements, and that becomes the level of medical decision-making complexity that can go into the coding criteria. One note is this applies, not only does it apply across all specialties that use these codes, but it applies to new and established patients equally the same. And that becomes clear in the documents that are coming up. So I'm sure you can read this. I can't, but the AMA put this out, and these revisions become effective January 1st, 2021. But these are the parameters for medical decision making in the new coding process. Note here underneath is the direct link to this that you all can do and get, so you can have this for your own. It is, on a letter size paper and landscape formatting. It is very legible in the hard copy form. It's just not very reproducible. So if we go down each of these and break them out by areas, problems, data, and risk, they kind of start to look like this. So when we're looking at the problem area, you notice the codes go down the left, the straightforward, the decision-making level, straightforward, low, moderate, or high, and then the description of what's required. So the level 2 visit here, whether it's a new patient or an established patient, requires 1 self-limited or minor problem. As you go to low, it's 2 or more self-limited or minor problems, 1 stable chronic illness, or an acute illness or injury. And again, we get down to increasing levels of complexity. As we get to the level 5 codes, it has to be 1 or more chronic illnesses with severe exacerbation, progression, or side effects of treatment, or an acute or chronic illness injury that poses a threat to life or limb, life, sight, or limb, right? So this might be really tough to get as we look at, as most of our office visits. It may be very difficult to achieve a level 5 code in this area. Now, again, there are two other areas. So the next area is the data reviewed, and this is too broad to put on one slide. It's actually spread over 3 slides. But there are anywhere from 1 to 3 categories in this, and you have to meet at least one of the two. So you have tests and documents, usually as one category, an assessment requiring an independent historian. As you go up in complexity, again, test or document and any combination of these, independent interpretation of tests that we talked about, what that means, or a discussion of that. As we go down further, and I know I'm going through these quickly, but as we come down here, this category may not be as difficult to achieve a high level as the others, but again, you need to have 2 or 3 to be able to get there. So again, so far, problems, find your spot on the list. Data, find your spot on your list, and then go down to risk. The risk comes basically from your intervention or your plan and what the risk is. So if you don't change a whole lot of things, you're going to be in a level 2. But if you change prescriptions or write new prescriptions, talk about surgery, and those kinds of things, or look here, diagnosis or treatment significantly limited by social determinants of health, which means you have to document why that is. You would have had to document in your note why this applies. And if you spend a lot of time doing that, that can kind of carry over into your coding now, whereas before it really didn't. And then level 5 is that high risk area. And I gotta say though, when you look at level 5, this is drug therapy requiring intensive monitoring for toxicity. This is major risk. This is requiring hospitalization, decisions to not resuscitate or de-escalate care. Now, these are only examples, but it's this level of risk that many of our office-based encounters won't get to, right? So again, the first and third categories, the problem and risk, might be difficult to get up to level 5. That may just be my impression. We'll see how it pans out. But I'm thinking it's going to be a little bit more difficult to really make a level 5 if we're really honest about things. But it's also going to take a whole lot more documentation of specific things to be able to get there, not just how many boxes you check or how many things you examine. It's how much you actually do. And that's one of the things that I think is really intriguing about this. This really looks at what you're actually doing for the care of the patient, which I think is actually a benefit and improvement. But again, it remains to be seen. So just as there was a new code for prolonged service time for when looking at time of service, there's a new code looking at medical complexity and E&M complexity. This was presaged before as a placeholder G code, which was this G PC1X. It's now G2211. It gets an additional RVU credit of 0.33. This is the CMS quote, and its intent, what its intent is. But basically, it's to recognize comprehensive, longitudinal, continuous relationships with the patient, and involves delivery of team-based care that's coordinated with others. And so, part of this confusion on my part was CMS had thought that this would be used for 100% of the visits for providers that are providing continuing care for a condition. And even in the 2021 rule, they thought that this might go down to 90% with delayed entry. But, you know, I was wondering, well, if that's the case, why didn't you just put it in there, right? Um, and it's used for new and established patients. It can be used with any E&M code, and it can be used by any specialist that does this. Well, if that's the case, what differentiates it? And thankfully, others had the same issue, and thankfully CMS came up with, here's how you should use it, and here's how you shouldn't. And I think they made it pretty clear. So you can find this again in that link. If you look at the final rule, page 278, this is an exact quote all the way top to bottom of the CMS example where you can use it. And look at what we're talking about. This is a Medicare patient, relatively young Medicare patient, with at least 3 conditions: heart failure, diabetes, and gout, on multiple medications, who comes in for an established patient visit. So they talk about the heart failure symptoms. They talk about the diabetes, and they're going down through things. The clinician adjusts the dose of some of the medicines. Oh, by the way, I have a pain in my right. Oh, by the way, I know I'm here for this, but I have this. So it's an add-on, right? So we adjust the chronic medications. We talk about acetaminophen for the joint pain. We order tests for the chronic conditions. Oh, and while you're here, we should really do your Pneumovax, and you're due for colorectal cancer screening. So let's go ahead and order that screening colonoscopy for you. And so if we look at this is the all of everything, right? But if we look at team-based care, and your huddles and everything, this could no longer be a surprise in the visit, because during the room-in process, your medical assistant found that out, and you're ready for it on the front end. They already looked and knew the patient needed a Pneumovax and colorectal cancer screening, and warned you about it, and they actually put in the orders for you. So it's easier to get to these things, but you're addressing all of these things, right? And so you're doing looking at all of the patient's conditions across the spectrum of diagnoses and systems, with consistency and continuity over time. So for all that, you could use the G2211 code in addition to the E&M code for the visit. Another benefit of having team-based care delivery models embedded into your daily operations, and this can help you do that, it will also help now pay, because you get additional reimbursement and additional wRVU credit. It can also help pay for the additional staff and the workflow changes that are required in team-based care. So I know I'm going off a little bit on a soapbox about a couple of things, but this is how you use the code. This is where the code comes in, but this is also how it can apply to your clinical practice transformation process and help pay, literally, for it. All right, so where don't we use the code 2211? And this is basically, when your visit is focused only on an element. So again, not specialty specific, but circumstance specific. So if you're just there and you're looking at a fracture and you don't look at anything else, then you can't use this code, regardless of your specialty. If you're there and it's a URI and you're only focused on the URI, then you can't use that code. So I'm back to, there's no way it's going to be 100% of the codes no matter what, because many of our, especially our acute same-day visits, might fall into these kinds of categories, or seasonal allergies, or gee, I think you have reflux, or I'm really worried about this mole. Yeah, I'm worried about that mole too. Let's send you to a dermatologist, and that's all you do. Then you can't use the code. So I don't think this is the CMS's understanding of, I think it'll be 100%. I don't think it's anywhere near that. It's going to be complaint related or care delivery related. And anyway, that'll help you with that. That is a new code that'll go into place January 1st. I think it does have a great place and recognizes, comprehensive continuity of care and team-based care delivery and working on preventive services and pop health management all at the same time. And it gives a little bit extra incentive to do that because now you get paid for it and you get workload credit for it where you didn't before. So I think it's a good thing, but I don't think it's something that everybody's going to use 100% of the time. I think it's going to depend on the encounter and may help us be more comprehensive on our approach to the patients with every encounter. All right, after a deep breath, looking at E&M code RVU changes. Now, CMS, again, trying to recognize the burden of care and recognizing how care delivery has changed over the last 15 or 20 years. They're looking at assigning different RVU values, recognizing the additional direct care provider responsibilities associated with office encounters. So, we talk about patients have a greater degree of complexity now than we're dealing with than ever before. Our requirements with the EMR documentation and how much time is spent on EMR documentation is incredible. And if we're really going to do pop health and work on care coordination functions, we need to get recognized for that somehow, right? So all the things that we've been complaining about that aren't captured in very well in the coding elements have been trying to be addressed in this way and by CMS. And so here's what the changes occur. Now there are no changes in the lowest code. So the 202 and the 211 really have no change. But there's fairly significant change in all the other codes between the current RVU value and the 2021 RVU value. And by the way, here are the RVUs associated with those two new codes we talked about. So fairly significant increases, especially for established patients, right? Because these are the ones that some of those things of needing more time and all that kind of stuff. We had a fair amount of consideration for the new patients, right? Because they were new to us, and so we were getting pretty good credit for those. So the increase there isn't as much as it is for the established patients. And again, that whole complexity code can add in there, so we're doing comprehensive continuity of care. Now, beyond those codes, there's the trickle-down effect we talked about before, and here's a listing of all those a little bit differently than in that initial introductory slides. And this is because these codes are at least based in part on the E&M codes that we just talked about. And in addition, in the review of misvalued service codes, these are codes, individual codes that are looked at every year by nomination or by CMS perception as looking at, we're not getting credit that we deserve in these codes, and we're not getting reimbursed, workload credit or reimbursement credit for these codes. Can you reevaluate, what you're assigning to them? In all of these areas, there's a trickle-down effect from the changes in the 99202 to 205 and the 99211 to 215 RVU changes. And so it affects many more things, and it's across numerous specialties. So not only the ones that are readily visible here, but also the ones in the misvalued codes. So very interesting elements and very interesting changes. If we look at the impact by specialty, the impact ranges from a -1% to 21%. And here's the kind of distribution looking out. So, it's a fairly significant change for many specialties. Now, these are only 63 specialties we looked at. And we looked at it comparing the 2020 with the 2021 Medicare provider utilization and payment databases. That's where we got this information from. And again, thanks to Eric and Neil for being able to put this together, because this isn't directly from the final rule, but it's extrapolated from the final rule based on that database. So fairly significant changes across the 63 specialties. Here's how it pans out by specialty. And again, these are calculated from there. Rheumatology, endocrinology, high, endocrine because of the, We'll just say they're high. Nephrology is relatively high, and that's in part the end-stage renal disease. But you notice it goes across specialties. We talked about OBGYN and maternity services, for instance. Primary care, family practice, you would look at some of those codes and say, yeah, of course, there are a lot there. And then there are some that aren't, that don't have. And many of these, besides infectious disease, which in many cases it tends to be an inpatient consultative service as opposed to an outpatient service. But you notice a lot of the procedural, procedural specialties, maybe not so much of an increase, right? Which, again, if you look at the total or the proportion of the office-based codes in question, again, 99203 to 205 and 99212 to 215 that are most impacted, these organizations or these specialties may not be, the proportion of codes related to that may not be very high, and so you might not expect them to be very high in this area. Relatively neutral, some of these are not unexpected either. Hospital medicine is going to be almost all inpatient codes, so will critical care, and some of these may not be that unexpected. Interestingly enough, diagnostic radiology goes down just a little bit. Alrighty, so those are all the increases. Those are the increases in RVUs, and we mentioned before that the conversion factor is what allows those increases to be offset by a decrease in reimbursement to keep everything budget neutral. So already cat out of the bag, conversion factor is going to be 32.41, down from 36.09, an absolute decrease of $3.68 or 10.2% decrease. It had been fairly stable. If we look at the previous years, right around $36. Last 3 years, right around $36, going down fairly significantly. Obviously, we're not going to recover that degree of decrease through the QPP incentives, because even if you're in advanced APM, you're only going to get a 5% offset. And if you're, the MIPS maximums have been just under 2%. So you're not going to make that up. And so what's the impact going to be? And the biggest thing to say is it will not be uniform across specialties. Just as the RVU increase was not uniform, the conversion factor impact will not be uniform across specialties either. And we'll look at the implications of that in just a second. But as we mentioned before, AMA, MGMA, and others are now lobbying Congress to look at options for relief. They didn't get any with the final rule, and so they're still hoping to get relief through Congress, and we'll see what happens. So what does this do to reimbursement? And this is probably the most predictable thing, and CMS actually has something out there to look at the impact on reimbursement by specialty. This is a lot of this is taken straight from the final rule. So table 106 that you can find, it lists the percentage of change of total allowed charges for 55 specialties, and the potential impact that you can then calculate, from which you can calculate the impact on your individual practice or employee network mix or individual. Now, this would apply if the historically rendered and claimed national service mix doesn't change, and the coding patterns or coding curves don't change. And we already talked that both of these may change, right? So this is if everything else remained the same and we only focused on what happened in the final rule, this would apply. So our coding patterns may change based on the difference in documentation, and how we render care may change a little bit based on these changes. But if nothing changed, this would be the impact. So if everything historically, if your mix of services, historically, if your coding patterns hold up, then this is what you can predict. This prediction is based on the conversion factor, RVU changes, and those things that are in the final rule. It does not factor in any of the QPP stuff. So this would be different. So if you're doing the calculations, this is what it would be, and then add in whatever your QPP payment change will be for 2021. So when we look at just the at only the final rule impact on total allowed charges, it goes anywhere from a decrease of 10% to an increase of 16%, and it varies by specialty, and that's a huge span of change. And so here's how it plays out. If we look at a positive change, it makes you in the black, negative change in the red, and neutral, yeah, just gray zone. Endocrine kind of leads the pack as far as increased and positivity. Family practice is up near the top. And so, some fairly significant increases in some of these, and most of these are non-procedural, right? There are a couple of procedural in here, but many of these are non-procedural specialties. Neutral we'll leave for the moment. Some significant specialties in neutral. And if we go to the negatives, some fairly significant negatives up on this end, and radiology is really taking a hit, both diagnostic and IR really taking a hit, but so are others of the procedural specialties. So a lot of the procedural specialties getting a hit, a lot of the cognitive specialties getting a benefit. This is almost reminiscent of some of the previous RBVS changes, and I'm missing a letter in that. But some of the changes before, which started directly the RBRVS changes in the past, it started to put greater emphasis on cognitive specialties as opposed to procedural specialties. So this is playing out again in this scenario as well. If we look at it across the board, the positive impact in about 38% of specialties, but more pertinently, that means that the negative impact is about 62% of specialties, right? So many more specialties are going to experience a negative impact on reimbursement based on the 2021 changes than are going to experience positive. So probably going to be a net negative for most of us. And again, calculations can be made to figure out what the exact impact might be as you look to 2021 and try to predict reimbursement, knowing that it won't be absolute, it'll be directional. The impact on provider compensation, well, it's going to be highly variable, right? It's going to depend on the type of comp model that the providers have, and it's going to depend on the impact of the documentation changes on individual coding patterns. I mean, it's going to be real tough to figure that one out, to be honest. So I think what most people are doing is just assuming that everybody's going to have the same coding patterns and we'll see what happens. Others are saying, well, maybe we can just see what 2021 holds for the change in coding patterns and then make decisions after that. So the actual impact, though, and what you're able to do with this is going to depend in a large part, with what your provider contracts allow as far as latitude. We've encountered some clients whose provider contracts say it will be the current year Medicare conversion factor. And that's what we're going to multiply our wRVUs by, for instance. So for those individuals, there's no latitude, and it's going to be a direct impact. There are other clients that we've encountered where the compensation rates, and that's really actually the same instance, but they're tethered directly to the Medicare conversion factor. And that's the example I gave us. So I'm sorry, I got a little bit ahead of myself. And then the other depends on whether the organization feels it's prudent to try to accurately predict the actual impact of changes precipitated by all aspects of the final rule. And that's that whole thing that I was mentioning just a minute ago about, what's it going to do to our coding patterns with these new documentation requirements? Where are we going to end up with all this? And in large part, how much can we afford? If our reimbursement is going to be going down based on the calculations we just did on reimbursement, and these individuals are going to expect to have increases because they're on a productivity-based compensation model, how do we reconcile that, and can we afford it? And we need to calculate all that to make sure that we know where we stand. There are some generalizations that we can make based on provider compensation model type. So for instance, on the straight salary model, there's really no change, right? Because it's straight salary. The major impact is how well the organization can afford that. So if we're paying a pretty hefty straight salary, but our reimbursement revenues are going to go down considerably, the affordability becomes an issue. Straight wRVU model, clearly, change by specialty, consistent with credit RVU levels and relative utilization of the CP codes with changes will have a direct, huge impact on the RVU model. Now, some specialties will have a larger impact than others, as we already talked about, but there's a huge implication if you're on a straight RVU model, or also if you're on a base plus incentives, and the only real incentive that's driving things is individual RVU, because that behaves like a straight RVU model. Revenue minus expense, clearly is going to be reimbursement driven, right? So if revenue goes down for the same amount of work, man, it's going to be it's going to have a direct impact on comp. And then base plus incentives, it will depend on the degree of impact will depend on the degree of reliability on the CPT codes with RVU changes, and that'll vary by specialty. If you're also targeted more towards non-productivity, then productivity may have less of an impact versus the others, as we already mentioned. So many factors are going to impact on the compensation issue, and a lot of what we do with this is going to depend on the latitude in the contracts, but also the latitude in talking to the providers and trying to work through it. We need to be able to strike a balance of related to sustainability. We can't, for most organizations, you can't just blindly go into it and say, oh, yep, we'll go with the 2021 RVUs and regardless of our decrease in reimbursement, and we'll just move forward. Boy, that's going to create a huge issue with sustainability. So I think it's really a matter of working with the providers, figuring out what to do. We're thinking that many will likely, if we had our druthers, we think most should spend most of 2021 trying to find out what's going to happen with the documentation changes and the coding patterns, and spending a lot of time on education, audits, and all that to make sure we're getting that right in the first several months of 2021, allowing at least 6 months of data to know where we stand in that, see what really happens with our reimbursement in Medicare, and since that's often 90 days in arrears, it's going to take 6 months to really have a good feel for that. Use the latter half of 2021 to see how well our predictions of our heading into 21 calculations were, see what reality shows, and then see where we can get to. We think most would try to stay with the RVU credits for the 2020 level or 2019, 2020 level, and then look at implementing changes coming out of 2021 and going into 2022. I think the biggest thing is, to be successful, we can't act unilaterally. We have to involve the providers, and we have to work through to develop mutually agreeable and sustainable solutions to this. This is a huge difference. I'll be honest, I didn't think there was any way that CMS would come out and actually do what they had published in the proposed rule. I told people as much, and it's a good thing I'm not a gambler, because I would have lost everything, because I thought there was no way that CMS was going to go through with what they proposed. And lo and behold, they did. So it's going to create a lot of variables for us to consider. It's a huge, in my mind, it's a huge issue. It requires a lot of attention. And I think it will, require ongoing calculations, monitoring, and keeping an open mind to changes through 2021, coming out of 2021 with a real good idea of what we're going to do in 2022, and having the providers on board with that. So with that, that covers most of the things. There are many things that can be covered in much greater detail, giving examples of coding and all that kind of stuff. But we went much longer than we usually go. This is almost 90 minutes. I thought it would be about that long to cover everything. Hopefully the nice thing about this format is you can pause it and come back to it and take bathroom breaks if you need to. I hope this was beneficial to everyone. I think it's fairly comprehensive and accurate. The one the one issue is the whole time piece, but again, I think what we presented is as accurate as we can be. And I wish you well with these changes. And again, thank you very much for attending this educational session. Take care now. Bye-bye.